Hello and welcome to the ARTP YouTube channel. My name is Ed Parks, clinical scientist at UHCW. Welcome back to ARTP sessions. It's fantastic to be back. We've had a bit of a break, but hopefully we're back now, bigger and brighter for 2022. Are you new to ARTP sessions? Have you not seen any of our videos before? Well, don't panic because I'm going to explain how it's all going to work. So ARTP sessions is going to be a series of informative topical discussions with a panel of guest, expert and volunteer speakers on various aspects of our profession. We've previously recorded 2 videos and these focused on how healthcare scientists were redeployed from their respiratory and sleep departments into other areas of their hospital trusts during the COVID-19 pandemic. 2 excellent videos, so do head over to the ARTP YouTube channel and give those a watch. And if you enjoyed watching them, then please do comment, like and subscribe. So moving on to today's topic, cardiopulmonary exercise testing. So without further ado, let's take a deep dive into ARTP sessions. So very excited to have our guests with us today. A selection of guests that some may refer to as a trio of heavyweights when it comes to CPET. So I'll let them introduce themselves. So if you just want to let us know who you are, where you work, and just give us a bit of an introduction about your involvement with CPET. If we start off with Karl, moving through to Andy, and then finishing with Joe.
Oh, hi everyone. So my name's Karl Sylvester. I'm head of Respiratory Physiology across both Royal Papworth and Addenbrooke's hospitals. So my foray into CPET started many years ago. Probably as I was doing my PhD, and at the moment currently lead on the ARTP CPET course, faculty member for the Cambridge UCLA CPET course, co-wrote the guidelines with good Andy himself at the bottom, underneath me. I don't know where you are on the screen as far as you're concerned, so I will head down to my fellow Brady Bunch member, to Andy.
Hello everybody, so I'm Andy Pritchard. I'm been working in respiratory physiology for about almost 20 years now. I currently work as the Deputy Service Lead for Royal Wolverhampton NHS Trust. I've been performing CPET for over 10 years. I currently work as the Clinical Service Lead for CPET in my trust. And I'll hand over to Joe.
Thank you. Yeah, Joanna Shakespeare. I'm a consultant clinical scientist in Coventry. When I was in Birmingham prior to moving over here about 14 years ago, I did some CPET. We used to do exercise tests on the transplant patients in Birmingham. And then when I moved over to Coventry, I basically established the service over here. Started out doing aneurysm assessments and building that service. More recently, I've just finished a thesis looking at armagometry. We'll probably touch on that later. And I really interested in the complex breathlessness and trying to identify what's going on with patients using CPET.
Brilliant, thank you for those introductions and sort of the outline of your involvement in CPET. And I think all 3 of you really gave a clear description of how well we can use CPET amongst a broad range of patients in a variety of different clinical cases. And I think that will shine through with the questions that we're going to be, or the discussion points that we're going to be having. So we'll start off with a very contentious subject amongst CPET. Should the VO2 line be red or blue? Now I know that this can divide. So does it divide the panel? What are your thoughts? Starting with you, Andy.
So I've always been red, to be honest. Simply because my justification, I always think of oxygenated blood, oxygen, red. That's my only justification for it.
I'm going to go with you, Andy. I go red, oxygenated blood. It needs to be red.
Oh, you're sitting there in a blue top.
It's got to be blue. It's got to be blue. Yeah, I look. I don't think it really matters which colour you put it at, as long as you know which colour's what when you're actually doing the test. I think you're absolutely right. You know, a lot of people choose red because of oxygenated blood being red. I think some people choose blue because the sky is blue. You think there's a lot of oxygen in the sky. Oxygen tends to be blue. So that's really the only reason. But I think as you know, if you shift departments, you obviously need to be aware someone may have had it in blue, someone may have had it in red. You just got to make sure that you're looking at the right parameters when you're interpreting the test.
I think it's important as well to make sure that your colour is consistent throughout your system and reports and across multiple systems. So you don't want to be sort of mixing things up if you're using one colour on one machine and one colour on another, or your reports are coming out a different colour to what you're looking at on the screen. So that's really important. So
standardise the colours, make sure you know which colour is referring to what, and make sure you double check before you do any interpretation.
Yeah,
absolutely. And make sure it's red.
So moving on to you now, Andy, then. So ARTP have recently published a set of CPET guidelines, and I know you're presenting this at conference, so I don't want you to go into too much detail, but are you able to give us a bit of a description of these guidelines, pick out any pertinent points that would be really important for us to take back to clinical practice?
Absolutely. So we wanted to produce a document that would sit alongside and complement the 2020 PFT statement, which came out just before. We sort of, amongst ourselves internally, decided that probably too big a document to contain within that PFT document. So we started work on it about 4 years ago. It took that long to put together. We were supported with an excellent team of authors, and every one of those authors brought something to the table. And it was really great to sort of use their knowledge and experience to formulate the documents. And really, we wanted to, from the get-go, we wanted to produce a practical tool, if you like, for physiologists and other healthcare professionals to use in the performance of CPET. And really, just to touch on a couple of sort of key points that I'm particularly proud of within the document. We were quite strong with our contraindications section. We wanted to move away from some of the more traditional lists of patients that you can't test. And some of that was informed by some of the questions that have been asked on the ARTP forum. So we really wanted to give back to the members. And we really promoted a modern approach. We really wanted to push thinking about risk versus benefit, rather than that list of a discrete list of people who should not be tested, because we didn't really feel that always represents a modern way in which CPET is deployed. Yeah. And ultimately, in that section, we wanted to show that if it's done correctly, CPET is quite a safe test to perform, which is obviously reassuring to people that are coming to the test as new practitioners. We had an excellent quality assurance section. I'm particularly proud of that. We suggested some regular short-term audit processes, which were aimed at increasing quality within service delivery. And we made a recommendation around a variety of different options for biological quality control. And then another section that I'm particularly pleased with, we made some suggestions around staffing and competency. And we really wanted that to form a foundation to sort of springboard us as ARTP into starting to think about national competency framework and certification of CPET as we move forward. We've also put some paediatric considerations in there. We felt that was important, and we felt that area of the document was quite well represented.
Fantastic, brilliant. Karl, do you want to add to that at all?
Yeah, I was gonna say about the paediatric section, and probably good to have a discussion about that, because there is quite a significant difference between testing adult patients versus paediatric patients, and I think it's very clear when you go to see a paediatric CPET service the differences. So for an adult service, what you tend to find is that the CPET practitioners wouldn't really be talking to the patient during the test. The reason for that is that you want the patient to be able to continue the exercise test without any distractions. As soon as you start talking to them, that sort of highlights them, they're doing exercise. You see their breathing pattern change, the RER starts to change during the exercise test as well. So we tend not to speak to the patient until we get right to the end of the exercise test and it looks like they're struggling, and then we'll start to give them some encouragement. Obviously, during the exercise test, if we feel that there's any safety issues, then we'll speak to the patient during that time, but we'll ask them not to talk while they're doing it. But then if you go and see a paediatric service, they are talking to that child the whole time. That's the only way you're going to get them to motivated to get the exercise test done. You know, if having kids myself, and everybody else on the panel will know this, if you stop talking to a child, they just lose interest, so they will just stop cycling. So a particular good lab that I can sort of recommend if people want to go and see paediatric exercise testing is up in Glasgow. You know, they do the testing really well on their paediatric patients, and I've seen them in action, and it's a sight to behold, watching Paul Burns in his Glaswegian accent egging on a young child. It's a very good experience.
Good, brilliant. Joe, do you want to add anything further on the guidelines?
Yeah, so what I wanted to say is they're not just a guideline, really, are they? What I think they are, which is absolutely excellent, is they are a manual for somebody who's doing CPET, has a service, a CPET service, because I think it covers absolutely everything about the CPET, not just the performance. It is right from the start, all the considerations through consent, all the contraindications that you talked about. So I think it's really good. It's a really good service manual, I think, not just a set of guidelines. And I do encourage people to read it, because there will be some things that will be new to them and things that they could implement. The other thing that I think is really good, and Ed will understand this, as an IQIPS accredited centre, we're about to move into IQIPS Standard 2 for next year. The fact that you've put those audit considerations in there is absolutely brilliant, because that is exactly what your IQIPS assessors are looking for. And sometimes we get blinded to what we're doing, and we can't think about how we could audit. And we're supposed to do horizontal audits, we're supposed to do vertical audits. It all gets a little bit complicated. And then when you see things like that written, I think it's really useful resource for people. So I congratulate you on the work that you've done. It's really good.
Yeah, absolutely fantastic document, really is. So thank you for that. So sort of as a young scientist, I always remember sort of overemphasizing the numbers that we were, achieving from performing tests. And when I moved over to CPET, all of a sudden I had lots of graphical representation of the data to look at. And obviously with CPET, we produce lots of plots, and we refer to them as plots. So in terms of what plots to use, because there are different ones, what are your thoughts on using different plots? Are there any ones that provide us with different types of information? Should we be using more than one? Starting with you, Joe.
I don't think it matters which plot you utilise. And we've got within the team, within our software, we've got a variety of plots. And that's because individuals in the team like to look at data differently. For me personally, it's what I grew up with. So I'm old, so it's the original Wasserman plot, because that's what I grew up with. So that's what I've learned. So I can look at a Wasserman original 9-panel plot and I can see straight away what's going on. If you shove the ERS plot in front of me, I'm going to have to think about what it is that I'm looking at in a little bit more detail. So I don't think it matters. I just think you need to understand what the plot is and maybe use the same plot each time so you can very quickly visually look at differences between patients.
Karl?
Yeah, I think people can get really hung up on the numbers, and Joe's right. You can look at a plot. You can pretty much walk into a room, see a 9-panel plot or the one that you're used to, and immediately be able to identify whether there's an abnormality or not. I mean, to some extent, it's similar to spirometry in that you can look at the flow volume loop and know whether there's an abnormality or not. But you then utilise the numbers to assign a severity, to see where the abnormality is, and whether things have changed over time. So from my perspective, again, you have the plots that you're used to. Now, I use all 9 plots because I think you need all 9 plots to be able to see what's going on. But then I guess sometimes it depends on the patient population that you're seeing. And if you know, so for instance, with a preoperative assessment, there are certain things that you're looking for, but there's always other pathophysiology that this patient who's presenting with a preoperative assessment might have. And the number of times that you'll do a preoperative assessment, you're looking for VO2, you're looking for oxygen pulse, but actually you identify something else because you have those other plots available. So I know that Chris Cooper obviously is very keen on just the 4-panel plot. He feels he can get what he needs from a 4-panel plot, but I still think from my perspective, you're missing out some things by just having the 4 plots that you won't see. An example might be dysfunctional breathing or breathing pattern disorder. Using those 4 plots, you can see that there's probably an issue, but you then need to look at a different plot to go, well, actually, I now know what that issue is because I can see it on this plot over here.
Okay, thank you. Andy, what do you use in clinical practice?
So I use the UCLA Harbour 9-panel. Again, like Joe, it's what I've always used. I'm comfortable with it. I know where everything is. I think if you look at the literature, there's been calls for standardising, 9-panel layout. And I think really that's just to promote sort of inter-operator and intra-operator sort of consistency. But I think really, if you're using what you're used to using, then that's probably the main thing. As long as all of the information is there that you need, then you're not going to miss anything, particularly if you apply a systematic approach to sort of looking at those graphs. And I know that for me personally, I've got my own methods for when I look at tabular data, when I look at the graphical plots, how I'll work through my 9-panel. And I've actually adapted my 9-panel. I've got graph 9, I've got SpO2, I've got breathing frequency on graph 7. So these are things that are useful to me. And I think for practitioners out there, there's no right or wrong answer. And there's a certain amount, particularly with modern systems now, of ability to tailor what you're looking at to suit the service that you're providing. And I think that's important. I think the key thing really is if you're distributing those results out to other clinicians or other centres, as long as they're aware of what you're using, and that would avoid any pitfalls, I suppose.
And I think Wasserman as well, he in 2012 he moved some of the plots around from the old style, and that was just to line everything up so that everything was in the right place. But I think once you get used to a certain way of looking at graphs, it doesn't matter whether they're lined up or not. You can see what you're looking at. Maybe if you're starting out, it's quite useful, but when you build a bit of experience, however they're laid out, as long as you know what you're looking at, it's fine.
Yeah, absolutely. It's a very good point. I mean, it seems that all four of us will use different sort of methodologies in terms of what plots we use, but I assume that we would all get to the same outcome when looking at a CPET test result. So I think that's the important point, isn't it? That as long as you can justify what you're using, how you're using it, like Andy said, have that systematic approach to producing sort of a clinical outcome. And that's really, really, really good. 2 words: maximal test. So a lot of trainee healthcare scientists often ask me, how do I define a maximal test? And I have my own way of defining a maximal test, and I can explain it to a certain extent. However, what are all your thoughts on how do we actually define a maximal test, and what parameters do we use in clinical practice? Starting with Andy.
So I assume, Ed, that from now on you'll refer those trainee healthcare scientists to the statement on CPET.
I certainly will, yeah.
So we did cover this in the document, and we sort of identified some of the pitfalls. The biggest one, perhaps the most controversial one, is perhaps RER, which tends to be a go-to for many practitioners out there as the gold standard for maximal effort, or defining or determining maximal effort. And there's certain caveats that you need to take into account with that, with regards to sort of breathing pattern, hyperventilation, and that sort of thing. Before you start pinning all of your hopes and dreams on an RER greater than 1.1 or whatever. So we have made some recommendations in our paper. I think you need to be careful if you're looking at an RER less than 1.1. I think there's a recent ERS document that came out that suggested 1.05 was acceptable, and I think that's been determined in the literature that would underestimate exercise capacity in a lot of individuals, a significant proportion of individuals. So I mean, for me personally, when I'm testing, I'm looking for evidence of exercise limitation. I'm looking for plateau in VO2. I'm looking for heart rate. Is it getting up there? Are we exceeding 90%? Is there any evidence of ventilatory limitation? That sort of thing. We don't always measure lactate, but that is obviously something you can look at as well.
I mean, just because of the broad range of patients that we're testing and sort of, I suppose, the individual approach that may be required, should we be using fixed thresholds to define a maximal test, Joe?
No, I don't think that's possible. And having tested 116 normal individuals for my thesis on the arm and on the bike, that variation in normal response from everybody means you just can't have that fixed threshold. I'm so glad to see that RER moved out of the box within the guidelines and was a discussion point rather than a fixed point, because I've had difficulty with an RER of 1.15. I do think that 1.1, and certainly looking in my population, 1.1 was more realistic. But I think the things we have to look at, the first thing is watching the patient. So if you're interpreting and you haven't actually been in the room, you're relying on that good information. How was the patient performing? What were they physically like at the end of the test? So that visually is going to give you a really good idea. And then, like Andy said, what's the heart rate? In a respiratory patient, what was their ventilation? How high was their ventilation? The work rate they achieved as well, unless they've got a reason such as a neuropathy or COPD. So you're not expecting a good work rate. But in normal individuals, you'll be expecting a decent work rate. So all these things, looking for them to have achieved towards the peak on at least one of these things, and physically they've demonstrated. So their Borg score or RPE, were they really pushing themselves for you to be able to say that it was a maximal test? And then it's like, does it always matter if it's a maximal test? Because it depends on what the clinical question is, doesn't it? And I'm not saying we shouldn't try and achieve peak VO2s in our pre-ops, because AT isn't the only thing that we should look at, but can you answer the clinical question with the data you've got? And so does it really matter if it's completely maximal or slightly submaximal?
Yeah, absolutely. And you've mentioned about patient self-reported levels of maximal exertion. Karl, do you use those, and how do you sort of weight those against sort of the numbers that you're getting from the actual test?
Yeah, I think there's a difference between physiological limitation and symptomatic limitation. So we've got all of the parameters within the guidelines around what we would deem to be physiological maximal test, but you have to take into account that the patient feels they can't do anymore. So in terms of the physiology, we may assume that it's a submaximal test, but if they're giving you Borg scores on a scale of 0 to 10 of 9 or 10, then really we have to assume that that is a maximal test for the patient. So when we're reporting it, yes, we report whether it's a submaximal test based on the physiological parameters, but we're also taking into account how the patient's symptoms are. And sometimes that's quite a good tool for using during the interpretation as well. So if you're seeing that physiologically they're submaximal, but their symptoms are coming out as maximal, then there's a disconnect there somewhere. Yeah. And you can usually then send that back to the clinician to say, clearly we have a disconnect between what the patient perceives they're doing compared to what they're really doing. And so what can be done in order to resolve that situation? Because I remember John Moxham many years ago, I think he had lots of clinical students that would come in and they'd say, well, we can't find anything, so there's clearly nothing wrong. And he would say, but the patient is saying they're breathless, so there is something wrong. Whether you're finding something or not doesn't matter. The patient has presented with a symptom of breathlessness. There's a reason for that, and you need to investigate it. Don't just assume and push them aside because you're not finding anything on any of your physiological investigations.
Yeah.
Can I ask my co-panel about lactate? So about whether you measure it. So recently we've just started to take capillary blood gases mainly in our respiratory patients, and we managed to get the lactate switched on the blood gas analyzer. So we've just started in some patients. Do you measure it regularly? Is it something that you do use?
It's on the blood gas. I can't say that we particularly put much significance on it. We use the other parameters and other panels more than we'd use the lactate. We might use the lactate to see whether they've gone past the lactate threshold. Does that match up with what we're seeing in terms of the metabolic threshold on the panels, etc.? We tend to use the blood gases more to look at AA gradients, so we can distinguish between hyperventilation versus a gas exchange abnormality. But Andy, do you put
same, exactly the same as you, Karl. So I mean, we've and similar to Joe, we've just recently switched on our lactate module on our blood gas machine. It's something we're planning to utilise moving forward, but primarily we use the CBG at the height of exercise for gases, similar to you, Karl, just to look at that AA gradient.
And when we're talking about blood gases, obviously Joe has mentioned at Coventry we use capillary blood gases. Does anybody use arterial blood gas sampling? No, everybody's shaking their head. Okay.
In extreme circumstances, if it's absolutely important and we can't get a capillary blood gas for whatever reason, they're just a lot more difficult to try and get, especially at the end of exercise when the patient's puffing away. You're trying to extend the wrist and you're trying to keep it in a steady place. Capillaries are much easier.
And even then, I think they're not always easy to get right at peak exercise either, are they? It's trying to get that timing correct, isn't it? I think they're going to stop very soon. Let's try and get that blood gas now.
A good question for you guys though. So I mean, I know that certain places, and we used to up until fairly recently, would use a scalpel blade and a bung behind the ear to jab the ear to get the blood sample. But we've had to move across to automated lancets. What are you guys using at the moment?
We switched to lancets quite a while ago, actually, and it took us a while to get the right lancet with the right depth, and they were working very well when we had access to cream that would vasodilate the ear. Now we're relying on hot water. I find that unfortunately it's not nowhere near as effective as it used to be, unfortunately.
Yeah, we use automated lancets as well, and I've always gotten quite well with them. Yeah, I don't think I'd fancy taking a scalpel to an earlobe, but
it's a shame that people won't have the experience anymore of standing next to a treadmill while someone's jumping up and down trying to get a blood gas out of someone's ear and hoping that you've got your aim right. That was always quite a nerve-wracking experience.
You teach that on the course, Karl?
Well, we can do if you want to be a volunteer, no problem at all.
That can be a video for another time.
Yeah.
So Karl, you mentioned about bouncing up and down on a treadmill. Of course, there are other modalities of exercise that are available, predominantly the cycle ergometer. But Jo, you've mentioned that you've recently performed exercise testing using the arm ergometer, and that's formed your thesis. Are you happy to talk to us about what you found out and what you did?
Yeah, so arm ergometry, I'm sure most people are aware there is another modality, and you can exercise with your arms. And interestingly, there was an audit of preoperative CPET centres across the country back in 2018, and 5% of centres reported using arm ergometry for their pre-op assessments. The problem with arm ergometry is that we don't know what a normal value is. So we know it's less than when you exercise with the legs for all the obvious reasons, much smaller muscle group, different fibre types, different oxygen utilisation. So we know it's less. And it's always been estimated to be about 70% less VO2 than if you cycle with your legs. But we do recognise there are some patients who can't use the bike or the treadmill. So there is the potential to use an arm ergometer in a big group of patients. So what I wanted to do was develop some reference values so that we could use arm ergometry and actually have proper predicted values specific to that modality. So yeah, I tested, I've got data from 116 normal individuals. They performed both arm and leg ergometry. About between 3 days and 7 days apart for most people. And I've developed some regression equations. So I do now have some regression equations, and I'm now in the process of validating those with another subgroup of individuals and hope then to be able to publish it. So systematic review previously has said that about 900 mil per minute is the difference between arm and leg. I actually found mine to be a little bit less, and I think that's because most of the arm ergometry testing historically has been done in males and young males, whereas I had just over 50% females in my group, and I had a bigger age range than anyone else has. So hopefully my data is a little bit more representative of a bigger population. So hopefully those regression equations will be available to others. And if there is anyone out there who uses arm ergometry, then I'd really like them to get in touch with me, because ultimately I'd really like to build a database of data and try and grow this, because 116 to me is a lot of patients, because I did it predominantly by myself. But in the scheme of things for regression equations, it's not a huge amount of patients. So I'd like to grow that and improve that. So if anyone wants to get in touch with me, please do. Yeah,
absolutely. Yeah, please. And if you do, then you can drop some comments in the comments box below. Andy, Karl, do you have any experience with using arm ergometry? No? Have you been on one at the gym?
It's the one everybody avoids at the gym. The other thing to say is that my anaerobic threshold in my normals, 50% of people had an AT less than 11. So I do worry, if people are using it preoperatively, what are they actually using to make decisions around surgery? Because 11 is not the value to use when you exercise with your arms.
No, and that was...
Sorry, Karl.
I was just going to say, yeah, I mean, that value was generated from cycle ergometry, wasn't it, rather than arm ergometry. But I think it raises a good point. Sorry, Ed, I don't know if you needed to move on to another question. But this perception of using an AT of 11 as a cutoff as to whether someone's appropriate for surgery or not. One, that's not what it was designed for. It was to say whether the patient was fit for surgery or not. And secondly, the problem with using a single cut-off, and, you know, like we teach on the ARTP CPET course, somebody can look at an 18-day, the four of us could look at a CPET result, we assess where the AT is. Well, two of us could put it at 10.9, two of us could put it at 11.1. So, you know, depending on how we've interpreted it, you could put them somewhere. And I think this is sometimes a concept people new to CPET find difficult, and especially clinicians, anaesthetists, they want that number. They want to be able to say, right, well, if I've got that number, I know where I stand. Unfortunately, CPET and a lot of pulmonary function is not like that. There's a range involved in what we're looking at here.
And I was just going to say, with the recent publication that Greg White was involved in, which demonstrates how important exercise is and keeping fit if you have cancer and how it can improve your outcomes. I'm just wondering whether it could be our remit, it might not necessarily, but it's whether or not we should be giving patients some information around what is a minimum level of exercise. Because what I've noticed so much since the pandemic and testing normal individuals is that people don't realise how easy it is to decondition, and actually how hard it is to get your fitness back. And I'm speaking personally here. But could we start putting some information together for preoperative patients about, you know, how many steps to do a day, but also the fact that you have to get your heart rate up. So I know we've tried to speak to our HPV team about having these kind of conversations with patients. It's whether or not we could start to lead on this and put some information together as to, you know, if you really want to get fit or try and maintain fitness at a decent level, this is the kind of level of activity that you need to do.
I mean, on all of our reports, we put a little section around training plan, and within that, it's the heart rate zones. If you want to improve your fitness, these are the heart rate zones that we suggest you exercise to, and it's usually around the anaerobic threshold.
Yeah.
Now we could have a big debate about whether that's appropriate or not, exercising around your anaerobic threshold, but it's a guide for them to be able to use. So not too high that they're not going to be able to sustain it, but not too low that they're not going to get much benefit from it.
There's obviously lots of healthcare scientists, you know, after listening to us talk, who are going to be really interested in getting involved in CPET. How can ARTP help them do that? What is there available to help support up and coming healthcare scientists getting involved in CPET services? Starting with you, Karl.
Obviously, I'm going to plug the ARTP CPET course.
That was my plan.
Yeah, that's going to be the first one. So, yeah, we put on an ARTP CPET course, 3-day course. Day 1, how to perform the test safely and to a quality standard. Day 2, how to extract the data, how to analyse it. And day 3, pulling that all together, how to interpret it physiologically, but also providing a clinical interpretation as well. And obviously, the ARTP course is based around the CPET guidelines, so probably just make some slight adjustments to this year's course. So we have got a course running in June up in Glasgow. We had high precedent numbers last time we put it on, the first face-to-face one in November 2020 that Joe kindly presented at. So we've got another one in June, and then we're planning another one towards the end of the year as well. But as we're also based from the CPET guidelines, putting together some competency frameworks so that ARTP can begin to deliver, if you like, ARTP certification to become a CPET practitioner. Andy, I don't know if you wanted to maybe put some meat to those bones. I know we've got our first meeting coming up, so we haven't finalised the actual details. We're in the process of discussing it, but
I hear you racing ahead of Team NIV.
Yeah.
Yeah, so we've I think it's very early days yet for the certification process. I think as a brief sort of overview, there's going to be a leveled certificate sort of program. So you can go in as a sort of a practitioner or as a reporter, or you can do a combination of both. And it just give you that certification and that accreditation to say that you're competent to practice and or competent to report, or both. Just to come back to sort of your point, Ed, about, you know, what sort of access have the members got to get involved with CPET. We've also run a couple of ARTP CPET forum meetings, these special interest groups. We've run a couple so far. They've been really well received, and the plan will be to continue to deliver them. There's been a bit of a hiatus because of COVID-19, but we've got a team of people that are raring to go to deliver them. And just a bit of an overview of those. They're sort of events for the members, by the members, if you like, and we invite interested people to come on, interested ARTP members to come along and present their case studies, and we have case discussions, and we've had a real mix of people bringing interesting cases that are, you know, rare to see. They're not quite sure what they're looking at, and we've had some real debate. We've had people coming from Pediatrics that have bought their CPET reports that they just want a bit of advice on, or just want to showcase what they're doing at their trust. And generally the days run sort of all day long. We have a plenary session in the morning. We've had a couple of great speakers that have come in. The first session was a really interesting presentation about quality assurance, calibration, and sort of quality control, in particularly aimed at CPET practitioners. And then we've also had a really interesting presentation around sort of CPET use for preoperative assessments, which I think the members that attended on that day particularly found useful, because not everybody is doing preoperative CPET.
Yeah, brilliant. And Joe, you've had involvement in the CPET course, and
yeah. So, well, unfortunately, I didn't attend in person to the CPET course. I've just joined the faculty, but I did do my presentation remotely. What I wanted to add is academic route for CPET moving forward. So the STP curriculum was reviewed, and the new curriculum is being launched for STP students as of September of this year. But the way the curriculum has now been redesigned is that there is a CPET unit, that module that is standalone. So what we really want to be able to do moving forward is to be able to approach those universities and ask them whether or not they will be able to deliver them for other people to access. So if somebody in your department, yes, they want to do the competency, but would also like an academic credit at master's level for CPET, then they'll be able to go down that route as well moving forward. So we will hopefully have all bases covered when it comes to CPET training.
Absolutely. So there's a vast array of ways to get involved with CPET with the support of ARTP.
And can I just say as well, for people that are starting out with CPET, these groups and forums and networks are absolutely vital. I remember when I first started, and I sat down in a room of people that are far more intelligent than me, looking at these 9-panel plots, and I thought, I am never going to get this. Never in a million years am I ever going to understand what all these dots mean. But do you know what? Over time, if you talk to people, if you network with people, the ARTP CPET forums are fantastic, but you probably need a bit more exposure than that. If you are starting out on CPET, see if there's a regional one close to you within your own hospital. Sit down, discuss, talk about things. Try not to be so introspective about things. Look outwards from your department to see where you can get assistance and help from. That absolutely really helped me to get where I am. So I would highly encourage that.
Yeah, absolutely. And I echo that. I know Joe was kind enough when I started out in CPET to provide me with some sort of, what do you want to call it, Joe?
Mentorship.
Mentorship, yeah, okay. Bit of mentorship back in the day regarding CPET, and I went down to Coventry and I watched a few, and we went through a few sets of results, and that was fantastic. Perseverance as well, I think. I thought I'd nailed it. And then I went to the UCLA Cambridge course with Vicky Moore, and we cried on the way home. So I hadn't got it at all. But let's go back to the heavyweights in the room. So Karl, you've just given a bit of advice. So Joe, Andy, if a young healthcare scientist came up to you and said, I really want to get involved in CPET, what should I do? What should I be looking at achieving over the sort of the next 12 months to 5 years? How do I do this?
I think a good.
Oh, sorry, Andy, go ahead.
Go on, Andy.
Sorry. I think a really good base really is to get the understanding on how to perform your tests safely, understanding normal values and normal exercise responses is probably key as a foundation to build from, and then go from there. Like Karl said, exposure to testing, exposure to individuals, pick up from people. Nobody knows everything. I'm still learning after 10 years, and I'm not afraid to say that. But it's really useful if a lot of people see CPET as inaccessible, or there's a lot of people out there that are working in silos, and really, like Karl said, if we can network and sort of raise everyone's heads and just work together, we can sort of make CPET a bit more accessible. So it's just just reaching out really and finding out and talking to people. It's probably a good starting point.
Brilliant. Joe?
Yeah, echo it, exposure. So for anyone who's new to doing CPET in our service, they're literally, it's just lots and lots of repetitive exposure, and it's doing all the parts of the test. So they might spend a bit of time doing the ECG, they'll do a bit of time doing the prepping the patient, then there's calculating what work rate to do, they'll need to do all of that. So it's just that constant exposure, and, you know, we're expecting them to do 50 of these, you know, lots of practical exposure, because every patient's different. So you're going to get a different thing happen with different patients, or the equipment might break one time, and, you know, it's having the confidence, which button do I press when this happens? And that confidence only comes with practice and just having lots of exposure. And the everyday is a school day. I echo that. I'm still learning, so much so I put myself through the SCST exam recently, and I panicked that I wasn't going to pass, but I did. But having always been the lungs are more important, we've got to actually. I really enjoyed cardiac physiology, and now I'm starting to understand the cardiac physiology and actually look at an ECG and understand why lines are going in different directions, and what, you know, I diagnosed a bifascicular block the other day, which, you know, I never would have been able to do previously. So you can still grow, even if you think you know your CPET. There's always something else you can improve, you know, and get better at.
So I've just gone into the dark.
Yeah. You were sitting still for too long, Karl.
So with that sound and invaluable advice, we've come to the end of today's ARTP session, but we're going to end with a pub quiz style question. So our guests, and indeed myself, have performed a fair few CPETs in our time. So the question is, how many CPETs have we all performed when added together? So if you want to have a go at that, then just drop your answer in the comments box below. But unfortunately, I don't have any prizes to give away. Well, not at the moment anyway, so it will be just for pure fun. I want to thank each of our guests today, so Joe, Andy and Karl, for taking the time to be with us today. We've got many more ARTP sessions planned for throughout 2022, but we would like your suggestions. So if there's a topic that you would like us to cover, please drop a comment in the comment box below. As always, like and subscribe. Thank you ever so much, and I look forward to seeing you all next time on ARTP Sessions.